I would love to kick it off. So, welcome everyone to our latest edition of Maine Policy Pours, and we are really pleased to have you all here today for this very topical topic. With us today, and our main presenter is Nick Murray. He is the author of the latest report, COVID Catastrophe, which really tries to dive into, from the very beginning to where we are now, the whole history of COVID in the state of Maine, the state's response to COVID, the wisdom and lack of wisdom in certain things that were done along the way, and basically everything in between. The genesis of this report actually was not actually to make it a report in the first place, to be honest with you. Nick and I had several conversations months ago about sort of the state's approach to COVID and how it's comparing and contrasting to other states. A lot of the things that we've learned along the way, a lot of the data that we've collected along the way. And, you know, we had drawn a number of anecdotal conclusions about sort of what has been going on with the state's response to COVID. And I thought it was worthwhile to perhaps just take a gander at that, take a look at that and maybe produce something that was short and sweet and just gave you some of those evaluations and things that we've learned about where we've been and where we're going. As Nick did a lot of the work that was necessary for that short little blurb that we were planning to do, it became very apparent very quickly that there was just too much stuff to talk about. Too many things that we didn't know, too many things that we did know, too many things that we were drawing conclusions about that needed to be talked about. And as a result of that, Nick produced one of our more comprehensive reports on, frankly, any issue that we've done in a long time. And we released it in pieces on our website, mainpolicy.org. And you might have seen that on our social media channels as well, to kind of break it down into little bits for you so that you can sort of piece by piece digest what Nick has come up with for research here. And then, of course, we did collect it into a big total report called COVID Catastrophe, which we released all by itself as well. So I know some of you may have seen that. Some of you may have read that. Hopefully a lot of you have. And it's a good jumping off point for our conversation today. So the way that we're going to structure this today, given that our presenter is from Maine Policy Institute itself, and just in the interest of time and everything else, because I know that this is such a big topic that we want to get to so many different areas and questions and so much that we have to cover on this. We're going to not do our typical roundabout with the staff and ask everyone how things are going. We're going to go sort of bit by bit through portions of this with Nick. I'll kick things off here for us, but then the rest of the staff is actually going to be asking questions of their own to Nick. And as we do this, we want to hear from you as well. So obviously in the chat, as we always have, we'd love to hear your thoughts and your reactions to things. And if you have questions, go ahead and say so in that chat. Jake and I are monitoring it, so if you have a question, we will try to get to everybody. I can't promise we'll get every single question, but we are going to try to get to as many as possible, and we'd like to hear from you as well. So we'll go ahead and let you ask your question on camera also. So that's the quick rundown of how we're going to proceed here today. The only other thing I'll say before we kick things off formally is please do me a favor, and when you have an opportunity to ask a question or talk, I would love to hear from you, but let's keep it short. Because we got a lot of people and a lot of questions and a lot of topics that we have to get to. So I don't want to try to, have anybody filibuster or take up too much time here. We're going to try to bang through a lot of it. So that's my public service announcement before we get going. And now that we are getting going, let me start things off here, Nick, by a really quick and easy kind of, question to kick things off with you. The report itself, it covers so many different bases, but one of the most important things that it covers is our knowledge of what was happening and how things were evolving in the COVID story. So I guess my first question to you is, what did we know? When did we know it? And what did you learn through this process?
Sure. Thanks, Matt. I appreciate the opportunity to put this sort of thing together, and I appreciate the introduction. Thanks, everybody, for joining us. So to just preface where I started with this report, I wanted to take the perspective of state policymakers at the time that they were making these decisions. Obviously, it's easy to look in hindsight and critique those actions, but I really wanted to make sure that I gave them The benefit of the doubt, obviously, it was a weird time. We didn't really know what we were looking at, but still, in that way, there was a lot of data coming out. There were a lot of reports. We had some data from various surveys from China, from the cruise ship and whatnot. So just starting there, I wanted to look at what were policymakers, what data was available to policymakers in the beginning. And so a lot of what the state leaders in Maine and the federal government and a lot of states followed were these models from the Institute for Health Metrics from the University of Washington, the Imperial College of London model. But the thing about these models is that they all make assumptions upon assumptions, and they have to plug in variables for the estimate of a case fatality rate, how many folks die if they have COVID-19, a hospitalization rate of everyone who is a case, and the rate of asymptomatic cases and the rate of asymptomatic spread. So if you can imagine a huge equation that has these ratios populated within it, you can get varying degrees of things if, say, the case fatality ratio varies between 3.5%, 2%, 1%, 0.5%. So you can see how these models can sort of get blown out of proportion. The unfortunate thing was that federal officials and state officials were looking at this IHME model and the university, the Imperial College of London model, which had a large headline of 60% of folks were going to, or 81% of people in the United States and in the UK were going to be infected. This would result in 500,000 deaths in the UK and over 2 million deaths in the United States. So that's what we saw in a headline. So you take, these models are taking these numbers, these estimates from different studies, they're plugging them in, and then they give this wide range of what they believe will be the end result. That is taken as a headline. And that's sort of how this narrative forms. And that's what state leaders were looking at. That IHME model, like I said, they layer assumptions on top of assumptions. They assume that 30% of the folks who would be hospitalized would pass away. And they estimated that the case fatality rate would be over 3% initially. That would put it to the level of severity of the 1918 flu pandemic. And so with that starting knowledge, that's, I think, what spun a lot of these state leaders and federal officials off on this realm of, this is some of the worst, this could be the worst pandemic we've seen in 100 years. And that sort of led to this huge reaction. So when we're looking at the data that was available, one of the things that I like to point to is one of the very first interesting case studies we had of this was the Diamond Princess cruise ship. If we recall, that ship was quarantined off of the coast of Japan for 2 to 3 weeks in the month of February. There were 3,700 people who were passengers and crew on this ship. And once COVID-19 was detected on this ship, they were ordered to quarantine off of the coast of Yokohama, Japan. And it sort of became our first experimental case study of what happens with this disease in a contained area. That's why I think it's an interesting case study. So just to give you the numbers of that, after all was said and done, they tested all 3,700 plus of the passengers and crew. They found that only 19% of those people tested positive, even though you could assume that all of those people, that 100% of them could have been exposed. They weren't quarantined to just their rooms. They could leave their rooms and mingle about the ship. So it sort of becomes this petri dish, this floating petri dish, right? So after all is said and done, only 19% of those people have tested positive. 3 out of 4 of the folks who were infected, who showed a positive test, were over the age of 65. And over half of the people who were infected ended up not showing symptoms. So looking at that, I think that should have been an early indicator to state leaders and policymakers that this disease did predominantly affect those who were elderly. And there was going to be a large amount of people who, even though they were infected, did not show symptoms, did not experience any level of a severe case, which would have been a good thing to take into account. So later on, there are other surveys, including the Diamond Princess in mainland China. Those estimated that the asymptomatic rate was between 18 and 45%. The CDC has estimated 35 to 45%. So it all sort of comes down in that realm. But I'm just going to share this little graph here from a Lancet study that I also include in the report. It breaks down the case fatality rate by age group here. So I'm hoping that you can all see this. You guys have this on your screen, right? This graph. So this is from on the left. You see the breakdown of cases by age from mainland China, and then just from Wuhan province. And you can see that the rest of China, the case breakdown sort of, it mirrors what we see here today, that the majority of the cases are in the majority of the population, the folks that are middle-aged. Wuhan, clearly they couldn't control that outbreak as much, but those cases definitely skewed older. But just to look at the right side of this graph, the case fatality ratio, you can see that it really doesn't start to get over a serious rate over that like 1% to 2% rate until you get to looking at folks who are over 50. And obviously that risk becomes much higher the more elderly you get. And now we know that the comorbidities are a really important aspect of that as well. But that was just an early look. It was something that if policymakers could understand and see early on, I believe they probably wouldn't have moved to lockdown every single person and instead pursued a targeted approach. But we'll get into that as we move forward. So Matt, to answer your question, that's really where we ended up the starting point here, and that's just looking at that sort of stuff, thinking about those early reports. These were all published in March. And I really think that Governor Mills and Dr. Shaw would have had a more realistic view of this rather than taking these computer models that were assumptions layered on top of assumptions.
Thanks, Nick. I know the next question that wanted to be asked is from Jake. Jake, you had something?
Yeah, so where we are right now, we have extended our state of emergency 5 times now, I believe. And a lot of people wonder, why are we still under a state of emergency given, the scope of COVID-19 in Maine? And so my question to you, Nick, is what data and metrics should we be looking at to determine if we are still in an emergency, both from your perspective and maybe even what data you think Governor Mills and Dr. Shaw are most focused on in determining whether or not we're actually in a state of emergency currently?
Sure. So if you listen to Dr. Shaw's briefings, he'll mention 2 specific pieces of data that they look at, and that's the 7-day positivity rate of tests. So that's the 7-day average of all the tests that are taken in the last week. How many of those are positive? Early on in the scheme of this, in the spring and summer, Dr. Shaw was looking at a target of 2% of a 7-day positivity rate, because we were looking at South Korea and they were doing things well compared to what we wanted to do back then. And so 2% was his target for that. We're now at under 1%. We've been at under 1% testing positivity rate for at least a month, possibly 5 or 6 weeks, depending on how you look at that. The daily testing rate last week hit new lows. So we're showing that we're considerably expanding testing at this point. We have plenty of tests. And that rate is much lower. Another thing that he looks at is the case incidence per 1,000, which is, it essentially looks at how many cases are coming up, how many new cases do we have every day, and that's sort of an epidemiological way of breaking it down by population, so you can use that per 100,000 people. The way that I look at that is another way to measure spread is this R value, which we've heard about a bit, which as essentially a way to determine how many cases could potentially be spread from one person who has a case. So the CDC had estimated that it was 2.5, 2.5, 2 to 3 more people would be infected per case. Right now, Maine's R value is around 1. That's generally assumed as an outbreak is not growing. It's not reaching that exponential rate, which was the red flag that we were all told to look for when we considered the hospital capacity. So we wanted to avoid an outbreak that exponentially increases and grows and grows. If your R value is 1 or lower, that means you're avoiding that. That means you're essentially having this outbreak under control. Now, all 50 states have R values of under 1. So when we look at how the cases spread and at what point and as the time scale goes by, you see that R value drop significantly. And obviously after the highs of April and May, especially in the Northeast, you've seen that drop considerably as well. There's actually a new report, a new working paper from the National Bureau of Economic Research that show that once a particular region's cumulative fatalities from COVID-19 reach 25 total, within 20 to 30 days, that death incidence falls to 0. So the case curve hits a similar shape in every region, no matter what the sort of intervention mechanisms that governments are proposing. So now we're seeing this with the benefit of hindsight, obviously, but it's really showing us that these interventions aren't working as well as we were led to believe, or that we were told to believe that we needed to follow in order to pursue this. The really interesting thing that I've seen in terms of the metrics that they use is that we're constantly focusing on the case numbers. And we saw that in May when Jean Lambrew said that, we're going to try to keep case counts as low as possible. Obviously, that was a red flag to me, and that was kind of startling to hear because we had always heard that we wanted to keep the case counts low. We wanted to keep the curve as flat as possible in order to avoid hospital capacity. So to hear her say that we're going to keep case counts as low as possible until a vaccine is here, that signaled to me that our goalposts were changing. And we see that even today when they reference this wedding in Millinocket and all the cases that have come up since then. The CDC, the US CDC says that we're missing 90% of the cases that are out there. We only see 10% that are there. So at some level, the more that we search for these cases, we're going to find them. And so that's why I like to look at some more updated data and look at more incidences of the actual severity of cases. Mike, I know you had a question about that, so we can move along there.
Sure, thanks a lot, Nick. And I got to tell everybody, this is a fantastic report that Nick did. Please take some time, read this. I hope you can share this. Come to our website and take a look at it. It's fantastic stuff, and it got a lot of run nationally, and I can't thank Nick enough for his hard work on this. My question is to you, from all the data you uncovered, where we're at today in the state of Maine, should we still be in a civil state of emergency where the governor has this unprecedented power, essentially unchecked? I appreciate very much how contagious this is, but I think we all know now what the best practices are, that we need to wash our hands, wear masks, the social distancing. But should Maine be in a civil state of emergency that's quite frankly unprecedented in our lifetime?
I don't see how at this point the whole state being in a state of emergency makes sense. Even early on, I'm not even sure it made a lot of sense, Mike. And that goes to back to the point of what metrics are they looking at, and have those metrics changed, and at what point when we reach those certain thresholds, does this be lifted? And I think that's been a pretty wide blind spot in terms of how the state has communicated to the taxpayers and the folks in the state. Looking at some of these actual measures of severity, I would say that we're not in a state of emergency. So as opposed to looking at those case numbers, I think a real good way to look at that is ICU bed capacity, hospitalization rate, and as far as we've seen, we have gone way past the peak of that. We are now at a controlled rate of hospitalizations, even as we see these cases start to ratchet up a little bit. And as I said, if we seek, we'll find these. But a really interesting way to look at this for me is the incidence of influenza-like illnesses. And so this is something that the state CDC and the federal CDC track year over year through each flu season. And so what I've got here are the last 5 flu seasons. The percentage of influenza-like illnesses that are reported at these these health providers in Maine. And the numbers down at the bottom are the numbers of the week in the year. So you see it goes up to 52, which is the last week of December, to week 1, the first week of January. So this is how the CDC tracks the flu season. As we can imagine, it starts in fall and late October or so, and then kind of carries us here. The red line is where we are right now. The red line is this year's flu season. That black arrow is the end of the data, which is earlier this month. So you can see that, yes, we had a spike. We were facing a new disease, and it's a serious disease. Like you said, Mike, I don't want to downplay the severity of this, but I think the issue is where state leaders emphasized it in terms of relative risk. So we see that, last year we had a little bit more severe flu season than we usually do. That curve peaks in February and March, as we can imagine. And folks are sort of prepared for this. If you ask folks who are concerned about their health and maybe elderly or have some other health issues, you ask them if they're avoiding crowds in the winter, they'll say absolutely, because they know the risks of a flu season. That's something that we see every year. And so to sort of see this influenza-like illness reporting data drop to essentially just another year over the last 5 years, we're back down to this region where we would be anyway. And so I think that's something that we need to be looking at in terms of a holistic way to see this, instead of just looking at those case counts. And like I said, if you're looking at it in this way, you don't see that there's a state of emergency. So that's something that's concerning to me. Here is a bit of a pixelated view of the ER visits. And you can see we're back down below the beginning. We're back down below the height of the flu season in early February for these ER visits. Yet another measure of severity that I think is probably worth looking at. So we'll check those out later, but those other ones. But yeah, I just wanted to cover that for you, Mike, and show folks really what we should be looking at. We shouldn't be looking at the cases, the cumulative cases, because we're always going to find these cases, but the idea is how severe is this and how much of a risk is this to the population to then shut down the entire economy and impose these drastic measures on social interactions and all of that. So that's really been the main message of the paper. If you'd read the report, is that we need to balance these things and we need to look at this in a focused, targeted approach instead of these blanket heavy-handed policies that will have many more unintended consequences, as we've seen.
If I could chime in real quick,
You can. Go ahead, Jake.
Move on to the next one. Nick, the first graph that you just showed us there, charting the flu seasons, you notice that when you get right into the start of January, the first few weeks of the month, it ballooned way greater than previous flu seasons. So I'm just wondering, is there evidence out there anyway that perhaps this reached our shores or was more pervasive than we thought before it was actually identified by public health experts?
Yeah, Jake, that's a really interesting point, and we had an attendee ask a similar question, because there's an interesting report from researchers from Brazil. They had measured sewage samples of wastewater samples. They had scheduled these samples to start late October of last year and continued through March. They actually had to stop their sampling because of the shutdowns. But after the fact, they reviewed these samples and found remnants of the DNA of this virus in sewage samples in Brazil as early as November. So if you recall the timeline, we were told that this virus was discovered in central China at the end of December. I think it was December 30th or something like that was when the Chinese government had made known that this was around. And so to see this report, it sort of blows a hole in the entire timeline that we've been told, right? So this coronavirus, this new strain was found in sewage, in wastewater, literally on the other side of the globe, more than a month before it was supposedly discovered. And so that's like, Jake, that to me shows that we really have been, we kind of missed it. You know, we were told that we knew when this virus was. We knew the day that it hit North America, and we knew the day that it hit Maine. And as you said, the influenza-like illnesses peaking in January and February. There were news stories in Maine of the Sanford Christian Academy. The head there was mentioning that they are seeing this large influx of cases, and then later on, you know, he's quoted as saying, I think that we may have had this in the school early, and I'm inclined to agree. You know, how else could we be seeing this virus if it was identified in China at the end of December? How could we see it in Brazil in November? It sort of blows open the whole timeline. It blows open this whole idea that government can track this, and government through its actions and through force can sort of dictate how it interacts with us. That I think is a really dangerous idea, and this sampling to me of the wastewater in Brazil sort of blows that open.
Before we go on to the next question, really quickly, I want to once again put in a plug. If you have a question for Nick, I've gotten a couple of them. You can either send me a private message or just do something in the chat there. We're monitoring it right now, and we'll make sure to go to you in just a second. Just really quickly before we go to Heather, who has the next question, I will say two things. Number one is everything that Nick just said just proves that China lies about everything, because clearly that is where it originated from, but the when is very, very obviously much earlier than they had said that it was. So they lied to the world, the WHO, they lied to everyone. And back to what he was saying a moment ago about sort of like what the Maine CDC and Janet Mills and friends are doing and what they're looking at for metrics and testing, you know, things that are making their decisions for them. The frustrating thing for me is that they don't tell you a lot of that. For instance, the designations of schools, you know, county by county to be green, yellow, or red, the things that they're looking at are told to us, but there's no thresholds or statistical barriers or anything that would tell you when, you know, we are reaching certain types of concern or whatever from the state's perspective, which allows them to basically go by gut. You know, if they feel like they should make it yellow, they will. They don't have to be held to a standard that they themselves set. It's a sort of rolling variable. And you see that reflected in all the kind of data that they give us too. For the entire history of the pandemic, for instance, they just do not publish age cohort death data. I have been maintaining that in a separate list that I've pulled from media reports about this person being 70 and that person being 90 and this one's in Cumberland County and all this other information that is individually reported, but is not it's not reported with the rest of the information that you can find on the Maine CDC website, for instance. There's a lot of very pointless information on that website, and very important things like that are not put there. So it's clearly being used by the people who are in charge and are making these decisions as a way of trying to shape public opinion, to try to keep you as apprehensive and scared as possible so that it can justify the steps they've taken. They want you to be fearful of the virus, and therefore they are trying to make sure that that occurs and are trying to control information, you know, to make sure that that happens. So that's just my own observation, having covered this for as long as we've been doing. Anyway, all that said, I know, Heather, you have a question about COVID-19 data as well. So I want to go over to you, Heather.
Well, your transition was perfect. Thank you, Matt. Because the Maine CDC does seem to have been shielding some of that data to Maine citizens and the population, which has been pretty frustrating. For instance, the fatality rate that you just mentioned, which was included in our report. But I wanted to ask Nick how conducting this research has shaped how you interact and perceive and read state data.
I gotta say, it's really shaken my belief that this data is the best way to go. Usually, when you research stuff and you try to find the best citation or the best source for data, you look for the government data and you look for state data, and this has really shaken my belief in that. The state of Maine has really shown that it cherry picked what data it was using and what metrics it was using. And like I said, they moved the goalposts later on of what metrics they were even using, what threshold would be there for that metric, when things would change, and all of that. So you know, for instance, we didn't even see town level data in Maine. We didn't see municipal level data. We were the last state to see that. The state eventually released that on June 3rd. We never saw a time scale to that, so we couldn't see trends. We only could see where those concentrations were in municipalities. Obviously, it came down to what municipalities or what cities were more population dense. And that was something that, again, we knew early on. You know, that was something that about this virus that we knew it spread when people were close together in more dense areas. And the folks who were more affected were those who were elderly and those who had more comorbidities. And so it just goes to that same idea that the data was out there for the state, but they only used the data that would have helped kind of further their narrative. I mean, the CDC didn't release a daily positivity rate of tests, even though they were giving daily briefings. You know, they said because it was a lot of figures to crunch every day, but they eventually started doing that. It was something that many states were doing because it was important to understand day to day what was happening. And obviously that builds into that 7-day positivity rate and the 14-day they look at. So, you know, all of this, Heather, it comes down, I'm increasingly more skeptical of these state-sponsored scientists. And so, you know, I put in the paper that we should really be advocating for the separation of science and state, because when you have these scientists, these public health experts who are paid by state government, and they're employed by the state, and you have a governor who is unilaterally declaring a state of emergency and enacting policy based on her own adjudication of the scenario, you know, these state public health experts, they're not going to deviate from the line. They're not going to deviate from the state's preferred narrative. So it's not that these people are the only source of information, right? There's plenty of peer-reviewed data from academia, from the NIH. They publish these papers all the time. So I'm getting these graphs, you know, but conveniently it was not in the menu of data that was available to state leaders when they were making these decisions. And you know, there's an interesting story about where the idea of lockdowns came from, and I'll get into that a little bit later. But I think it really was they wanted to make sure that folks were following what they were saying, and so by putting out these case fatality numbers by age, seeing that folks who were most affected were those who were elderly and who had more comorbidities, they felt like it would lull us into a false sense of complacency. So they didn't want to say that. And Dr. Shah said as much. And so, you know, that to me shows that these state-sponsored scientists are not beholden to science completely. They're beholden to the state. They're beholden to their employers. And so that's why I would advocate for using academia, leveraging business and academia and the nonprofit sector, and not just the government, to help move solutions through actual society instead of shutting everything down and having the government sort of run everything from the helm there. I just wanted to address the wastewater treatment, because Regina Longyear, thank you for putting me back on track on that. I wanted to mention that in that report, there are citations that cite other wastewater samples from Paris, France, from Holland, from Murcia, Spain, and from Massachusetts that have tracked the remnants of the coronavirus in those wastewater samples and chart the incidence of that much earlier than the local case counts had shown. So it's not necessarily that, you know, the coronavirus was found in wastewater in Cambridge, Massachusetts in November. I'm not saying that, but I'm saying that the incidence of the findings of the virus, they showed an earlier surge of that in the wastewater before the surge of cases. So it just sort of backs up that idea that the timeline that we were told really was not tethered to reality.
I know that Jake and I have more questions, but I want to get to some of the audience ones too before we kind of go in that direction. So I know, Richard Hobby, you had a question that you wanted to ask a while back. I assume that we haven't had a chance to answer it yet, but let's go to you now and see what your question is. Let me make sure you get unmuted here. I don't know. Nick, can you unmute Richard?
Oh, yes.
I think you're the man here.
My
right?
apologies. Yeah, I'll add you as a host, Matt. My bad.
Great, thank you. First, Nick, a great report. Thank you so much.
Thank you.
A related question. Supposedly 170,000 or so people have died from the virus. But if let's say somebody's died in this panic, until there's a true coroner's report as to the cause of death, somebody with diabetes or serious heart disease who's, quite old and in frail health, if they die testing positive, they'll be listed as having died because of the virus instead of just with it and not really because of it. So my question for you is, when this is all actually, assuming we get honest coroner's reports, how many of the 170,000 that are now claimed by the media and by the left to be death by COVID virus will actually be just death with COVID virus testing positive, but having like the straw maybe that broke the camel's back, or even not even that? Do we have any way of estimating that right now, Nick?
It's hard to know until you have all of those coroner's reports and you have those death certificates. And there are some researchers in some states who've been able to obtain this. Similarly to the as I mentioned, I put it in the report. I put in a request for data from the CDC for nursing home deaths and how that broke down by municipality. I haven't gotten that yet. I imagine it would take something like that, a Freedom of Information request, to access that. But similarly to the answer I got from them is that they can't deal with that request right now because they're dealing with the epidemic and all of that. So, it's hard to say right now until we get those death certificates, but you may have heard in the UK, they removed about 5,000 deaths from the COVID tally. And that amounts to close to 10%, I believe, of their total deaths. So they removed that because of the way that it was being counted. Like you said, folks who had tested positive at the time of death instead of it being the cause of death. So for instance, an ally of ours, the Freedom Foundation in Washington State, just recently sued the state so that they will represent the deaths in a more specific way. And so they'll be breaking down the deaths. I don't believe they have yet, but this lawsuit or this campaign that Freedom Foundation has pushed has actually moved the state to do that, to break that down of, is it one case or one incidence of COVID-19 with other factors? Is it the only factor and all that? So obviously there are more ways to break it down than just folks with COVID-19 who passed away, like you said. But let me just show, I'll pull up this graph here that really shows the stark difference by age, and it also stratifies it by underlying conditions too. And I think that was something that we really missed early on, was we weren't told that the comorbidities and that the age was a really big factor. And that goes to sort of our recommendations and findings in this, is that if we had targeted the response and really looked to those folks who were most at risk, we wouldn't have had to shut down the whole economy. We could have leveraged the solutions and the creativity of other institutions of society. There were charities that shut down for weeks and weeks and couldn't help folks. And so I think this, if we had known this, we maybe could have leveraged those resources a little bit better. So this is the hospitalization rate for folks by age, and then you can see the blue graph are the folks with underlying conditions versus the black without underlying conditions. That risk is almost double for all these age groups. And if you look at that by deaths as well, it's much more considerably skewed towards those who are older. Obviously, this is a really serious disease for folks who have compromised immune systems, for folks who are elderly, and for folks who have comorbidities. And that, to me, should have shown us, and we knew this early on, that should have shown us that targeted response really would have been the most appropriate way to go about it.
Yeah, I think your question, Richard, is an excellent one, and I think the real answer to you is we're never going to know, because I mean, even trying to place blame on anything specific for a death is really difficult when you have multiple causes. And we see this without coronavirus with things like the flu. I mean, I don't want to always, compare and contrast it to the flu, but somebody who's elderly, who has a number of health challenges as they already have, who gets the flu oftentimes will die of complications from that respiratory ailment.
Exactly.
And, you can say that they died from the flu, but in reality, they died from the flu and about 5 other things. And that's definitely true of the coronavirus as well. It's why it's so difficult to really pin it as the sole and single cause. And the other question I have is how many people are, have passed away this year from this, who ultimately would have passed away from something else that is very similar to it in a normal year. And we'll never know that. You'd have to have some sort of a parallel universe to be able to make that compare and contrast. So anyway, keep the questions coming in. I think I saw one a moment ago from Ryan Harmon. Ryan, if you're around, let's go ahead and unmute him and have you ask your question. Ryan, you out there?
Yeah. Is it unmuted? Here we
You're
go.
unmuted. Go ahead.
I had a couple questions. One question I had, I've heard that there's sometimes lasting effects of COVID. And if so, what percentage of those people that had COVID had those lasting effects if you came across an information? And the other question I had, which is a little bit different, do we need a national emergency, which kind of helps the governors, I guess, create these policies and cherry pick their policies, because that's where they're getting their money from right now? I'll let you go ahead and answer those two. And by the way, Nick, fabulous report. One of the best reports I think I've ever seen coming out of Maine Heritage. So, but great job to all you guys for that report.
Thanks a lot,
Ryan. Thanks, I appreciate that. In terms of your first question, it's pretty early to see, but we have heard some stories of even young folks who had a mild case are seeing some after effects. That's just something we're really not going to have full data on. It's hard to make those cases on the anecdotes. Similarly to this outbreak in Millinocket and all that, it's hard to make this policy and hard to extrapolate data from anecdotes. So we'll have to wait and see on that. But in terms of, what was your second question? Could you just remind me?
The second question was, we also have a national state of emergency.
That's right. That's right.
Kind of helps the governors. Yeah.
Thank you. Yeah. So thankfully, President Trump didn't declare a national state of emergency, which I think allowed some of these other states to experiment. For instance, South Dakota didn't pursue a full lockdown. There are other states who did that as well, Arkansas among them. But it allowed us to sort of see what the differences are and how this virus hit different regions of the country. More and more, we're starting to see that, like I said earlier, that this the curve of how we interact with this virus is very similar, really in every region, based on at what point did it actually hit that region, irrespective of what sorts of government policies were implemented there. And so, yes, the state of emergency on the Maine side, the civil state of emergency, does allow the state access to federal funds. And I believe at this point, every state is under a state of emergency, close to all, if not all at this point. Haven't found fully updated data in the last month on that, but I'm fairly certain that all are. So that allows the state to get those federal funds, which is obviously a large part of where we are now. We know that we're in a budget shortfall, and the governor has waited on that CARES Act funding so that we could maybe use it for backfill, but that's looking like that's not happening. So she was allowing those grants to go through. But ultimately, I think it's good that we didn't get a national state of emergency, because we could see these other experiments going on, and then we learned that it didn't matter what the state government did. The virus sort of ran its course, and that's because that's what viruses do. Here we are.
We had a question come in, a private message asking about, and I think this is an excellent question here. Is this virus, based on the per capita rate and kind of how it's run through the United States, is this a wake-up call that Americans are overall unhealthy, obesity and everything like that? I think that's a hell of a point.
Great point.
When you're talking about who is the most at risk for serious complications to this, there is no question that if you are overweight, asthmatic, diabetic, and you have anything that makes you have some kind of health challenge, that you are more at risk from a serious complication or death than you would be if you were an otherwise healthy person that looked like Nick Murray. So clearly the United States has that kind of a problem, although that is something that is not unique to the United States. I mean, you know, the entire Western world, the developed world, the first world, whatever you want to say, has a lot of the same problems. The UK is not terribly healthy either. You know, Scandinavia is, but, you know, France, Spain, Italy, you know, there's a lot of these challenges in all of these sort of westernized countries. And there was a related question about the overall rate in the United States versus other countries. And this is one I'm going to get up on a soapbox about. I hope you guys don't mind, but I've been tracking the entire world, frankly, in terms of the overall rate of infection, the rate of death, you know, whatever metric you can think of, and just trying to compare and contrast it to the United States. And the media's had a hell of a time, you know, making hay out of the United States having the most cases, the most per capita, all these other metrics that show the United States is terrible, really with the point of saying it's all Donald Trump's fault. I mean, it really comes down to that. I don't want to put too fine a point on it, but it's really political in nature. But when you actually drill down into the data and you look at the information, it is the weakest of all cases. For instance, if you take the United Kingdom, France, Germany, Italy, Spain, Ireland, and maybe one other country, I can't remember the other one, but those countries, you add up their population number, it is actually exactly the same as the United States, like plus or minus 500,000 people. They have, those groups of countries I just listed, have more people that have died of COVID in raw numbers than we have. And they have significantly less positive tests that have said that somebody tested positive for COVID. But when you go even further into the data and you look at their rate of testing, you'll note that they test about 70,000 per million. And the United States, the last time I looked at least, was something like 150,000 per million. So we test about twice as many people per capita than Europe does. So their number is unbelievably misleading in terms of the total active cases that they have, the raw number of cases they have, but the deaths and the rate of death of somebody who is testing positive for COVID both show you what's actually happening in these countries, and they show that they're struggling in the same way that we are. I mean, it's no different anywhere. There's no such thing as some sort of brilliant leader that marshaled the resources of their country and they were able to save their people from COVID versus a bunch of bumbling idiots that didn't do it right. There's certainly some countries that have handled it better or worse, but overall, we're kind of all in the same boat. And anything else is just political. So anyway, we want to wrap up things here. We got another 10 minutes, so keep your questions coming. I'm going to go to you guys in a second. But one thing that we haven't addressed yet, Nick, that I wanted to ask about before we move on to other questions is about the things that aren't COVID related that are happening as a result of the shutdown. I know that there's been some data about increased suicidal thoughts in the population. We've seen the massive increase in opioid abuse in just the first quarter, let alone what we're going to see in the second quarter. Yeah. And all this stuff is very clearly tied to what's been going on to try to combat COVID. So I just wanted you to talk about that a little bit and see if there's anything you've learned in all of your research so far about this kind of question.
Yeah, Matt, and that was a big part of this report, is that I wanted to make sure that folks understood the consequences of this policy and that this doesn't happen in a vacuum. Aside from the fact that there's not much that government can really do to control the spread of this, it's that there are so many other consequences from enacting huge wholesale shutdowns on all parts of society, designating non-essential businesses and essential businesses and all that. And so this CDC survey from the end of June, it tracked survey results from adults across the United States for the preceding 30 days of behavior, 30 days before that. So as you see here, 11% of adults in the United States seriously contemplated suicide in the month of June. And when you consider folks aged 18 to 24, that number becomes 25%. It's over a quarter of adults 18 to 24 seriously contemplated suicide in the month of June. And that, I think, is just indicates how fragile our society is and how much employment and the dignity of work and social cohesion contributes to mental health. And it's just clear that we see it here. I mean, as you can see, the anxiety symptoms, that was the highest rate. Any amount of anxiety due to the pandemic, I can understand that. But when you get down to things of the addiction rate and folks who had used substance abuse, who had increased substance abuse in the same amount of time, you see that as 13%. And then we get down to suicide. Those are the things that really worry me, that we don't understand the full effects of this on human behavior and on mental health, which is something that's it's tough to pin down. It's tough to track if you ask any public health official, but it's something that's really important, and you don't think about when you're only looking at one certain case study. And so, Matt, like you said, the overdose rates and the opioid epidemic, that has gotten much worse in Maine. You know, nationally, from last quarter last year to the first quarter of this year, there was a 13% spike in drug overdose deaths. In Maine, that rate jumped over 23%. The estimation of drug overdose deaths in the first 6 months of 2020 exceed the total number of deaths of COVID-19 in Maine. So, you know, we're looking at 250 to 260 deaths from opioid abuse. That's a rate that's gained 23% from last year. When also, you know, we're also trying to match society and control society based on a disease that has caused 130 deaths. So that's just to put that sort of in perspective. I found this other segment here from a researcher. I can't remember exactly where they were, but they were tracking other effects across the world of the lockdowns. And like you can see, I mean, the increases in domestic violence, that's all over the world, but also here in Maine as well. The Portland Press Herald reported that Helpline reports for domestic violence increased almost 50%, 50% between April and June compared to last year. And so these are, you know, between emails and texts and video, that rose 145%, whereas over the phone, it had risen 20%. This is really concerning, especially because these reports had decreased 17% from 2017 to 2018. So that these are real social issues that are exacerbated by making policy based on one single thing. We haven't even talked about the economic effects, and we're all very, you know, we're clear about that. We've seen the businesses that are closing. We've seen the unemployment rate skyrocket. Here we see, you know, the cross year-to-year unemployment rate. Since it ratcheted up in June, we thought we were going back down. Now we're getting back closer to that 10% that we were in the initial in April. These are some serious issues that not only contribute to economic health, but contribute to social health, mental health, and public health itself. I mean, these are public health issues that our response to the pandemic have exacerbated. And so that to me is a really big issue. That's just one of the reasons why we should allow, you know, civil society, these nonprofits to function and help people instead of shutting them all down and saying, oh, we'll let you know when you can open and when you can see your people again. Some people, that's their only social interaction, and it's a really important thing for humans, and sometimes we overlook that.
Let's go. We got time for maybe a couple more questions. Casey Hughes, I know you were asking about sort of some of those economic effects. So I think you're a good person to go to next. Casey, go ahead.
Oh yeah, let me unmute you, Casey.
Well, yes, get unmuted first, then go.
Yep, good.
Thanks, Nick. A lot of great stuff here, and I appreciate everybody's time. You know, for us, I mean, being downtown, I actually do go through the city with my mask on, but there are so many empty businesses that are just gone. And I don't know, you know, the governor, you know, I gonna call her the dictator. She took over, and she ran with her own rules because there was nobody at the legislature to really give her, you know, counterpoint on what was going on. But I think what's going to happen is, and they have no idea. We do a lot with the state itself as customers. They, you know, DOT and stuff like that. We print a lot of their stuff. They said, you know, well, all of a sudden we don't have any money. It was like, no shit. Pardon my French. It just doesn't, you know, if you're not collecting taxes, if businesses are going out of business on every 30 seconds. And I mean, there are so much open space downtown, and not just parking spaces, but retail establishments that are gone. And I don't know what the percentage is. You know, Steve Hewen said probably they're going to lose 50% of the restaurant business in the state of Maine. And you're going to see, oh, it's okay right now while you've got outside seating, but November comes, nobody's really going to want to be out there unless this vaccine, miracle shows up fast. I don't think anybody knows at the state level how bad the economic, catastrophe is. And that scares me more than anything else.
That's right. And we really won't know until the Secretary of State releases that business license data and that comes at the end of the year. But I would absolutely trust those estimates from Steve Hewins, the tourism industry. You need to have your finger on the pulse to know where they are, especially during the summer. That's 16% of jobs in Maine are tied to tourism. It brings in $2.5 billion a year in household income. That's 1 in 6 jobs are related to tourism in Maine. And I don't think that effect can be understated, especially when, like you said, the restaurants and the retail have been the hardest hit by this. So we really won't see those effects until the end of the year and maybe early next year in terms of raw data. But like you said, you see it. You see it every day. You hear it from folks. This is a serious problem, and we'll see these effects for many years. For instance, Mike Allen, the Commissioner of Tax Policy, estimates that we won't see prepared meals and lodging tax revenues equivalent to last year for another 2 years. So he's estimating it takes at least 2 years to get back. So we'll see.
If I could, just before I get into the last question, what I'll say, Casey, is that we've been trying our best anyway to track permanent business closures throughout the state, which is incredibly difficult to do. It's a large state. But if you go to our website, mainepolicy.org, right on the slider there, we do have a running list that I have put together of businesses that I can personally confirm either through media reports, contacting the business, using their social media, using their websites. They closed because of COVID. There are a lot of other lists out there that have been floating around that just any business that closed. These are COVID-specific business closures. I think we're a little over 85, and there's no way that that's the whole state. So if you have businesses in mind that you know of that are closed that are not on our list, please let us know. Send that information to me and I will do it. That's the best that we can do in the meantime until we can get some of that raw data. But it's the best means of quantifying it for policymakers at this time. And what I will say is that the vast majority of those closures come in food service. There's a lot of restaurants, a lot of bars, a lot of cafes, a lot of coffee shops. And when they were forced to close longer than 2 weeks after they were told you just need 2 weeks to flatten the curve, they were done. Most of those businesses operate on profit margins thinner than 5%. And when it's done, it's done. And so it's really unfortunate for those businesses. But just to put a bow on this, I know we're at the 1 hour mark here. The last question that we have for you here, Nick, what are some of the policies that we should change based on everything that we've learned, and what really is the ideal pandemic policy, if you will? Are full-scale shutdowns the right way to go, or is there a different path forward that policymakers never even told us about before they started enacting some of these broad mandates?
Well, that's the crazy thing, Jake, is that, this idea of lockdown completely throws away all disease mitigation precedent that we had before this. Usually epidemiologists look at this, you're either mitigating, you're suppressing, or you're eradicating. You can see that our policy has sort of shifted now to potential eradication and certainly suppression. But yeah, I think it's clear after we see this sort of a huge experiment. This is the first time we've tried lockdowns as a result of a new disease. And it's clearly bringing some large consequences, some large negative consequences. So ideally, looking in the future, we need government to understand that public policy changes are affecting an unfathomably large interconnected system. This economy is made up of millions of decisions that are being made by people constantly adjusting to their circumstances. And it's not something that any one person can understand or any one group of people can understand. You said, what policies are we targeting? Clearly, if we're looking at preserving hospital capacity, we need to get rid of certificate of need. That's something that Maine Policy Institute has been talking about for a long time, but there's no reason that hospitals need to get permission from the state and their competitors in order to expand their hospital capacity. That to me is completely asinine in the face of a public health crisis. So that'll be public enemy number one as we get back into the legislative session. But to really wrap it up, I have to shout out to my favorite social economist of history, and that's Friedrich Hayek. He has some great writings from the 20th century in the world of totalitarianism. He was able to observe this totalitarian socialist idea that government could control all of the economy and control all of life. But what it comes down to it is that not one person has all the information to do that. That's why we have markets, right? We don't have to know the avocado farmer in California or Mexico. We don't have to know that person's politics or anything about them in order to get the avocados at our grocery store and enjoy guacamole tonight, right? So this is what markets bring to us, is that they interconnect all of the system, and through prices, we have these signals of what's going on, where resources are needed, where they need to be reallocated. So it's really just understanding that, you know, government really it puts barriers up to pursuing resource allocation in an efficient way. And so if we have government that understands that by seriously altering the course of people's daily lives, you're causing more damage to what they would, to life than what they would normally be doing. As the last note, I would love to point folks to Donald Henderson. He's the man who is credited with eradicating smallpox. He wrote a paper in 2007 in response to the CDC's pandemic plan that initially put down this idea of lockdowns in 2006. That's a really interesting story on its own. But Donald Henderson, who eradicated smallpox, you know, he advocates that large-scale lockdowns and even these closing schools and banning gatherings and large-scale mask mandates and stay-at-home orders, all of these things, it will make it worse, because if you alter the course of people's daily life, you're disrupting the economy and you're disrupting society, and you're going to have these large consequences even on public health while you're looking to save public health at the same time. So this is somebody who really understands viruses and understands how viruses interact with society. I would absolutely recommend that folks read Donald Henderson's report from 2007. It's surprisingly easy to read for a piece on epidemiology, but that really sums it up, along with my good friend Friedrich Hayek here, that, you know, we have to demonstrate to folks how little they really know about what they can imagine they can design. It's not government that dictates how a virus spreads. It's nature, and that's the facts.
A good way to wrap it up there, Nick. And as another parting thought too, the compare and contrast between states should teach us a lot. I don't think it will, but it should. When you look next door to New Hampshire and you see what they've done throughout the whole pandemic, their numbers are actually better than ours for the past 2 or 3 weeks. They're at the very least, you know, on par with us in terms of daily new COVID cases and deaths. And throughout this whole pandemic, they have never had a mask mandate. They have a completely different school reopening plan. They handled their reopening of the economy much earlier and better than we did. They allow bars to be open. I mean, there's any number of differences between them and what the state of Maine has been doing, and their numbers look exactly like ours, frankly. And it has to do with a lot more factors like geography, population density, and many other things. Tonight, if you guys are going to be watching the RNC, for instance, you're going to hear from Kristi Noem, who is the governor of South Dakota, who had a completely different approach to COVID from the very beginning. And I think she's going to have an awful lot of interesting things to say. So I would definitely, if you're going to check out anything tonight, I would definitely check out her speech. But anyway, my point is that there's a lot of lessons that probably should be learned that I don't know if they will be learned because of the various political agendas of not only the people in the media, but also you know, public health officials and people that are trying to stump for decisions and justify decisions in reverse, looking backwards through time. So anyway, we're a little bit over on time ourselves. So I want to say thank you for joining us here today. If you guys want to get the report, go right to mainepolicy.org. It's on the first slider. Click on that, click on the download button, and you can go ahead and download the PDF, print it off if you want to, or just read it that way. If you have any trouble with that, though, just go ahead and give me, Nick, Jake, or anyone else either a call or an email, and we'll make sure to send it to you individually to make sure that you have it. But any other questions, let us know. We'd love to answer them. But thanks to Nick today for giving us this presentation and writing that report. And thank you all for joining us today, and we look forward to our next presentation next time. Thanks a lot.
Thanks, everybody.